Hi, everyone. I thank Professor Prapan and the entire organizing committee for inviting me to do this presentation at this prestigious Bangkok Symposium on the role of integrase inhibitors for first and second line in lower and middle income countries. All of you know that these are the various antiretroviral drugs approved for use in resource-limited settings. And we do have older drugs. We have several newer drugs in this list. And I will be talking particularly about this integrase inhibitor, and among them, particularly more on the usage of dolutegravir for first and second line in resource-limited settings. These are the two landmark studies, HPT and 052, and the START study completely changed our treatment guidelines, not only in the resource-rich settings, but also in the resource-limited settings. So what this guideline said is, someone who is HIV positive, irrespective of the CD4 start on antiretroviral therapy. Again, the World Health Organization very clearly recommended two different strategies to start treatment. One is on rapid ART initiation. There is someone who is HIV positive with symptoms, diagnose those opportunistic infection, put them on treatment, within a week start on antiretroviral drugs. Also, the WHO clearly recommended the same-day ART strategy. That is, someone who is HIV positive, they do not have any symptoms, counsel them, and make sure that they can take these medications and start on the same day. When we recommend these guidelines, we need to have a safer drug, which is easy to take by our patients, also been less toxic to them. In the past, you can see these guidelines recommended from WHO since 2010. We had used a variety of ART regimens in the past. Some of those which have been indicated here is either had pill burden with twice daily, or even if it was beyond once daily, had various different toxicities. In 2016, and following all those various documentations on adverse effects to antiretroviral drugs, dolutegravir-containing therapy was being recommended as an alternate regimen. Why it was recommended at that time was, this is based on the retrospective review of 4 different NIH-supported ACTG clinical trials. What they did in this study is patients who received antiretroviral therapy using efavirenz regimen were compared with patients who did not receive efavirenz but other ART regimens. So there are several trials being used for the retrospective review. There's one of the study called ACTG 5175, also been carried out in Asia, in India, as well as in Thailand, in Bangkok, as well as in Chennai. So in this analysis, what's it found that is, participants who received efavirenz-containing therapy, they had 2.6-fold higher risk of attempted or completed suicide when they have been assigned to efavirenz. So when you have been recommending to same-day ART or rapid ART, when you give such a drug, it's not going to be good for the participants who have been seeking this antiretroviral therapy. And also in the study, very clearly showed that the suicidality was much higher, especially in young people, as well as injecting drug use history, as well as with previous psychiatric illness. Also, World Health Organization's documents on the baseline resistance to NRTA-containing therapy has been rising over a period of time in various resource-limited settings in Africa, as well as in Asia and in Latin America, where it has gone beyond 5 to 10%. So following this, various reports on baseline resistance, World Health Organization very clearly recommended in countries where they have baseline NRTA resistance of 10% or more, you should use non-NRTA-containing therapy, preferably dolutegravir-containing ART regimen for initiating treatment. Again, why dolutegravir was used is based on the outcome from different clinical trials, from SINGLE, Flamingo, and SPRING, and SAILING. So what's been done in these various clinical trials is dolutegravir-containing therapy was been compared against either efavirenz or other integrase inhibitors or other protease inhibitors. One such study which I'm going to show here is a single trial. So here again, patient initiating therapy. where they used efavirenz-containing therapy was being compared with dolutegravir-containing therapy, as shown, in these graph. The yellow color code is on patients who are on efavirenz-containing therapy, and lighter shaded color is on dolutegravir-containing therapy. And x-axis is duration of weeks in follow, and y-axis proportion of the patient who got suppressed viral load of HIV RNA less than 50 copies. This very clearly shows that dolutegravir-containing therapy is been superior to efavirenz, over a period of 96 weeks follow. And this efficacy is not only seen in that single trial, but also in spring, in Flamingo and Saline, where efavirenz was compared against other integrase inhibitors like raltegravir, and also been dolutegravir has been compared against darunavir in Flamingo. Very clearly shows that dolutegravir is superior to those regimens. Also, among patients who had been failed with these ART regimens and patients who are on dolutegravir, they did not develop any resistance mutation as compared to non-dolutegravir containing ART regimen. When you compare the adverse effects, again, if you look into this the yellow color bar charts of patients who are on efavirenz, and the other color bar chart is on dolutegravir. It very clearly shows that patients who receive efavirenz, they have a higher CNS toxicity, particularly to dizziness and abdominal dreams, as compared to dolutegravir containing therapy. And again, adverse events to other ART regimens was being compared against dolutegravir. It very clearly shows that dolutegravir is much safer as compared to any other ART regimen for initiating treatment. So can we give this in tuberculosis? Efavirenz can be given in TB patients where they have been receiving rifampicin-containing therapy. So to understand this, a very nice clinical trial called Inspiring was being carried out in patients who had tuberculosis, where they received different ART regimens. One arm received efavirenz-containing therapy, another one with dolutegravir once daily, and based on the PK interactions between dolutegravir and rifampicin, where double the dose of dolutegravir is being given in one of those participants in this Inspiring study. This very clearly shows that if you double the dose of dolutegravir, that is 50 milligram twice daily, along with the rifampicin-containing therapy, it shows comparable efficacy, as compared to efavirenz and rifampicin. And again, following the outcome of this Inspiring study, it's been clearly recommended someone who has got tuberculosis and rifampicin, when you have been using dolutegravir-containing therapy, you have to double the dose of dolutegravir to 50 milligram, twice daily. Now, following all these various studies, WHO the year 2018 very clearly recommended to initiate treatment with a combination of tenofovir with lamivudine or emtricitabine with dolutegravir. That is, we call it TLD. At that time, the recommendation for pregnant women was using efavirenz-containing therapy. That's because of this large cohort study which was been done in Botswana called SEPAMO study, had shown some signals of dolutegravir in pregnant women who had received dolutegravir-containing therapy in the first trimester with some neural tube defects. Subsequently, analysis of the same study very clearly shows that there is no statistical difference between dolutegravir-containing therapy and as well as any other ART regimen among women who had received ART in the first trimester to neural tube defects. Following this, it's very clearly recommended dolutegravir-containing therapy for all population to initiate treatment. And again, among the different integrase inhibitors, we have raltegravir, we have elbitagravir, we have dolutegravir and bictegravir. Now, what's best in our resource-limited settings? When we choose a drug, it should fit into all population among patients who have got tuberculosis, or predominant of our patients presenting to care have tuberculosis, should be fitted to pregnant women, and should be easily taken, less toxic, and should have less drug interaction, and of course should be available in our own countries. If you look into all those different integrase inhibitors, raltegravir is twice daily, elbitagravir is available as a single tablet, but it requires cabecisat to boost that, and it has got a lot of interactions with other drugs. Dolutegravir, again, has been once daily, high genetic barrier, few drug interactions, can be combined with rifampicin, but you have to double the dose. It's safely given in women of childbearing potential, It's been co-formulated along tobacco 3DC as well as through our generics. It's also been available as the tenofovir 3DC and dolutegravir as TLD. In bictegravir, again, it's been available as once daily, but again, cannot be given in patients who are taking rifampicin-containing TB therapy. We do not have enough safety data in pregnancy. Following all these, dolutegravir is a regimen which can be given in all population, should be best recommended in a resource-limited setting among the different integrase inhibitors. Also, our group, in collaboration with CPEC in Harvard, have done a cost-effective analysis and how cost-effective use the dolutegravir resource-limited settings as compared to the earlier regimens like efavirenz. And we found that if you factor in all the adverse effects and discontinuation following efavirenz and following that developing resistance, again, dolutegravir-containing therapy is being very cost-effective in a resource-limited settings. Now, we do have generic tenofovir, lamivudine, dolutegravir as a single fixed-dose combination being available from several international pharmaceutical companies, being available as a single tablet. Also, our group here in Chennai have already evaluated these generic TLD combination, and it's been very clearly shown that it has been safe, it's been tolerable, and it's also been have comparable efficacy in a large cohort of patients of over 6 months clinical follow-up. Now, following these reports, WHO started recommending in their guidelines, and as well as many country programs started adapting the guidelines, and the scaling up of dolutegravir happened across different continents. In 2017 to 2018, around 50% of patients across different lower and middle income countries were receiving dolutegravir-containing therapy. Now, till 2021, now almost 90% of the patients who are receiving antiretroviral drug in lower and middle income country have been using dolutegravir-containing therapy, and it's been widely been recommended across different national guidelines in lower and middle income countries. What about in second line? Now, we know that very well that it's been recommended through the first line in the WHO guideline, as well as in the other resource limited setting guidelines. What about in second line? So whether can we give this dolutegravir in second line along with the 2 NRTIs when someone been failed with an NRTI containing therapy? It's a very nice study called Dawning study, so which recruited participants who had failed an NRTI containing therapy, and they are randomized into 2 different groups. One group received 2 NRTIs with dolutegravir, another one is standard WHO earlier recommended regimen of 2 NRTIs with the lopinavir. The study was well conducted, across 300 participants in each arm, and over a period of 52 weeks. And it very clearly shows that participants who are on dolutegravir-containing therapy, as shown in this blue color bar, is being superior in terms of virological suppression as compared to lopinavir, containing therapy. And following this is very clearly shown that dolutegravir-containing therapy for second line is being superior as compared to the earlier standard of care with the lopinavir-containing therapy among patients who have had failed in an RTI as a first-line therapy. What about tenofovir, which we use in the first line? Can we recycle, for second line along with dolutegravir? So this is a large cohort study which happened across the different continents in Europe, Latin America, North America, Sub-Saharan Africa, and Asia. In Asia, we had both India and Thailand being sites where any patient who had failed tenofovir, if they had a resistance mutations, and those data have been submitted to this large database called TNRS database, where it's been clearly shown that in Sub-Saharan Africa, patients who have been failing tenofovir-containing therapy, 57% of them had tenofovir resistance, and in Asia, where it's around 39%. So that means someone who is failing tenofovir in first line, they can have anything from 39% to 50% resistance either in Asia or in Africa. So following that, WHO recommends someone who is failing TLE, tenofovir efavirenz, you switch them to optimized second line ART, that is change from tenofovir to AZT3DC and from NRTI efavirenz to dolutegravir containing therapy. And this recommendation was done because there are studies done using dolutegravir monotherapy shows that which is not been efficacious. So if you switch to the same regimen, there is a possibility of dolutegravir monotherapy following this recommendation was done. Also, now there are various randomized clinical trials been ongoing to trying to understand whether switching from TLE to TLD can be a good option as compared to the earlier recommendation of protease inhibitors with NRTI, and also with the newer regimen of dolutegravir and darunavir without any NRTI. We need to wait for these results. In the meantime, the question started coming up: can we recycle tenofovir in a public health setting? That is, from changing from TLE to TLD. Very nice study conducted in Africa, in Kenya, Uganda, and Zimbabwe, on 464 patients who had a viral load of more than 1,000 copies following an NRTI-containing therapy. And they were randomized first to switch to either dolutegravir or darunavir 800 milligram, ritonavir 100 milligram. Then in a second randomization to either to retain tenofovir or switch to cidofovir. Is to answer the question, critical question: can we recycle tenofovir from first line to the second line? So in this particular study, which got published, shown that 58.5% of those study participants had intermediate or high-level resistance to tenofovir at the time of switch. And in the outcome at 48 weeks, it's been found that 90% of those patients are dolutegravir-containing arm, and 91.7% in the darunavir arm had viral load less than 400 copies. That means both dolutegravir and darunavir is being equally efficacious as part of those second line for among patients who have been failed in an NRTI-containing therapy. And also, there is no statistical significance that's been seen in terms of virological outcome according to the NRTI randomization, which again, they found that 92.3% of those participants in the tenofovir group and 89.6% in the ACT group had viral load less than 400 copies, and there was no difference in terms of rate of virological rebound, about 1,000 copies. So this NADIA study very clearly support the WHO recommendation of switch to dolutegravir for second line when someone who's been failing in an NRTI therapy. And also this study also stated that a combination of darunavir 800 and ritonavir 100 milligram is a robust alternative to dolutegravir in second line treatment, giving an excellent viral suppression. Also, this study very interestingly showed tenofovir and lamivudine can be recycled in second-line treatment, even in people with drug-resistant mutations. So that means you can switch from TLE to TLD, as shown in this table. That means someone who is failing TLE, you can change them to TLD, and thereby this dolutegravir can be a universal regimen for first line and second line, and you can recycle tenofovir based on this NADIA study. And one of the very important fact regarding dolutegravir, particularly for a systematic setting, is if you look into this single trial, if you look into those virological suppression, when participants were on dolutegravir-containing therapy, they had a much earlier virological suppression as compared to efavirenz. This will definitely have a huge impact on the transmission prevention, which we have seen in HPTN-052 study. Lesser the viral load, lesser chance of HIV transmission. Hence, in developing countries, introducing dolutegravir will not only have a huge individual benefit, but also it can have a prevention effect on this. But after seeing all those integrase inhibitors getting scaled up across different lower and middle income countries, one of those issues being faced in certain regions is on weight gain using integrase inhibitor. Now, this was very clearly shown in one of those clinical trials which was carried out in sub-Saharan Africa, called ADVANCE study, which was a 3-arm study, which compared tenofovir FTC dolutegravir and TAF FTC dolutegravir against tenofovir FTC and efavirenz. So in that particular clinical trial, which happened over a period of 192 weeks follow-up, very clearly shows a comparable virological suppression among all the three arms. When they looked into the sub-analysis on the weight gain, and if you look into those, this slide on the left side panel, among men, among participants who are on TAF and FTC and dolutegravir, they have a higher weight gain as compared to tenofovir, FTC, and dolutegravir as compared to tenofovir, FTC, and efavirenz. On the right side panel of this slide is among weight gain among women. If you look at it, there is a huge weight gain being seen in the dolutegravir arm, particularly when it is compared with the TAF as compared to tenofovir, FTC, and dolutegravir versus tenofovir, FTC, and efavirenz. This very clearly shows that in women race, particularly in African women, there is a huge weight gain when dolutegravir is combined with the TAF. This very clearly calls for much larger studies, whether it is race-specific or when it is combined in combination with the TAF. We looked into that into our cohort in Chennai among patients who are initiating dolutegravir-containing therapy. When we compared with efavirenz, we found there is a statistical increase in weight gain, and over a period of up to 12 months, then subsequently that significance was not seen. And also when they looked into the BMI at 6 months following TLD dolutegravir, we could see this BMI gain, and over a period of time that significance was not being seen. And again, in the resource-limited setting, we have seen in the past, when you put anyone on antiretroviral therapy, we have seen weight gain. Either it goes to the earlier regimen with nevirapine or the efavirenz, now hugely with dolutegravir. Again, the question is whether this weight gain will lead to another comorbidity. This is something will be a major research question, particularly in our region in Asia. So this is a very nice analysis, pooled analysis of weight gain among participants who have received different ART regimen, different phase 3 trials. This very clearly shows that the weight gain was seen particularly among Black females with the different regimens. This something really calls for whether this weight gain is race specific, particularly in the context of dolutegravir, I think, which should be answered with the cohort study followed by some pathogenesis studies to prove this. Coming to these COVID and HIV in the context of dolutegravir, we looked into literature review of all those published literature among patients who had been diagnosed with COVID with HIV with various ART regimens, and we found that there is no difference in terms of acquisition of COVID and the usage of ART regimen. In our cohort in Chennai, among 140 patients who are diagnosed with HIV and COVID, out of those 4,300 who's been seen in the clinic since this pandemic, 92% of them were on dolutegravir-containing therapy with tenofovir and lamivudine as a background. We found that no antiretroviral prevented COVID. So that means TLD combination did not have any prevention effect for COVID among people living with HIV and who are on antiretroviral therapy. And patients, again, who are on controlled HIV with CD4, they did the same like any other person who did not have HIV and had, COVID. And there is no difference in disease progression as compared to non-HIV as seen in our Chennai cohort. So in summary, the combination of tenofovir, lamivudine, and dolutegravir may achieve a goal of pill burden, high barrier to resistance and activity prior NRTA-resistant HIV. And people doing well on current therapy clearly will have a role since less toxic, more convenient, and offer greater flexibility. And again, in our region in Asia, we need implementation science studies as TLD is getting rolled up. We need to collect data on safety during pregnancy, and we need data on weight gain in our Asian region, and as well as long-term safety of a combination of tenofovir, lamivudine, and dolutegravir. As many of you know that now someone who has been suppressed tenofovir on a long run can be renal toxic as well as bone toxic. There are various studies being done. Now, can we drop tenofovir when someone has been suppressed? There are various two-drug trials being carried out, and some of them had been used in risk settings as a strategy to prevent certain side effects. This study called Gemini study, where two-drug combination of dolutegravir and lamivudine was being compared with tenofovir, FTC, and dolutegravir, and very clearly showed that over 48 weeks, it's been totally non-inferior. So following this, US FDA approved this combination of lamivudine and dolutegravir as de facto, but it's not recommended in hepatitis B mono-infected, hepatitis co-infected patients, and also emergence of drug resistance has been reported. And we need more data, particularly in TB patients, whether how we can double the dose without tenofovir. And again, a study on SWAD study where they used two-drug combination of dolutegravir and rilpivirine, particularly in patients who had a suppressed viral load, where tenofovir had been dropped and compared with continuing tenofovir over a period of time, and they found that there is no difference in terms of virological efficacy over week 48. Again, the sub-analysis of this study very clearly shows that patients who had continued tenofovir-based therapy had more bone mineral density loss as compared to participants who had dropped tenofovir and continued just two-drug therapy with dolutegravir and dolutegravir. This very clearly shows that dolutegravir can be used as a strategy to prevent toxicities as a two-drug regimen in different settings. Will this have a role in a developing country? Now, dolutegravir will be approved as a pill called Giluca. Of course, this can be used in patients even in resource-limited settings who are virologically suppressed with no prior NNRT or integrase resistance, and with no concomitant rifampicin and hepatitis B co-infections, particularly useful in patients who have got moderate severe renal impairment or osteoporotic and CVD risk. Also, I'd like to end my presentation by showing that now among patients who have got suppressed viral load, now we have a new tool using this long-acting injectable. So now it has been approved as Cabenuva, a combination of cabotegravir and rilpivirine. We know that cabotegravir is an analog of dolutegravir. It's an integrase inhibitor available both as an oral tablet as well as a long-acting injectable with half-life up to 40 days. Rilpivirine is an NNRTI available both as an oral tablet as well as an injectable with a half-life up to 90 days. So these two drugs been combined together as two different injections, and it's been shown in LATE-2 study that it's been comparable as compared to oral therapy, either as every 4-week injections or every 8-week injections. ATLAS and FLAIR, these are the two trials, very clearly showed that monthly injections with the cabotegravir and rilpivirine among patients who got suppressed viral load, who had oral lead dose with cabotegravir and rilpivirine, and followed by every 4 weeks of injectable cabotegravir and rilpivirine, have shown excellent efficacy over a period of time. So currently, this long-acting injectable is not available in resource-limited setting, should be available anytime soon, which will be a big boon to our patients who have issues with adherence. You have to look for this drug sometime soon in your countries. I'd like to end my presentation stating that our future treatment management strategies will be how we can reduce drug dose, how we can use certain new investigational drugs, also how we can use certain long-acting drugs in our antiretroviral therapeutic regimens. Again, thank you for this opportunity. Happy to take any types of question. And again, thank the organizers for this opportunity. Thank you very much. Stay safe.